to welcome all our participants to today's Antimicrobial Stewardship webinar titled, What Can the United Nations Do About AMR, or Antimicrobial Resistance? Today we have a highly accomplished international expert, Dr. Ramanan Laxminarayan. I am Marnie Peterson. I'm the Outreach Coordinator for the Antimicrobial Stewardship Project, which was launched by the Center for Infectious Disease Research and Policy at the University of Minnesota almost 2 years ago, in 2016. Before Dr. Laxminarayan begins his conversation with us today, I wanted to provide our listeners, for those of you that are not aware of his background, some of his bio here and his background. He's the founder and director of the Center for Disease Dynamics, Economics, and Policy in Washington, D.C., and is a senior research scholar and lecturer at the Princeton Environmental Institute at Princeton University. He's an affiliate professor at the University of Washington and a visiting professor at the University of KwaZulu-Natal. Dr. Laxminarayan is also founder of HealthCube, which works to improve access to healthcare and diagnostics worldwide. As I mentioned, he's really an international expert. He's been interested in the problem of antibiotic resistance since 1995 and has worked in this area. His work encompasses extensive peer-reviewed literature, public outreach, and direct engagement with 11 countries in Asia, Africa, throughout the Global Antibiotic Resistance Partnership. His prolific research has been featured widely through many different media and publication outlets, and one of his conversations and videos was viewed as a TED Talk as well. He's also tried to play a central role, and has played a central role, in bridging the issue of drug resistance to the attention of global leaders and policymakers, and as well to the United Nations General Assembly in September 2016. So once again, he's going to talk today about what the United Nations can do, and he's been active in this area and trying to engage policymakers for many years. He serves on the U.S. President's Council of Advisors on Science and Technology, Antimicrobial Resistance Working Group, and is currently a voting member of the U.S. Presidential Advisory Council on Combating Antimicrobial Resistance. He's also a series editor of the Disease Control Priorities for Developing Countries, which is in its 3rd edition. So he's had many other highly accomplished activities, has been involved globally, and a lot of his work has been covered in major media outlets, including BBC, CNN, The Economist, Publications in Science, Wall Street Journal, etc. So I'm very delighted that Dr. Laxminarayan had time to speak with us today to highlight his efforts and where you're starting to progress as you move through policy into action. So Dr. Laxminarayan, I'd like to welcome you to the conversation today, and our participants that are on, please engage with us via our chat box at the lower right-hand corner. You can send your questions to Dr. Laxminarayan. We'll have a lot of time today, 30 minutes or so, to be able to ask your questions. Thank you.
Thank you, Marnie, for that kind introduction. Good afternoon to all of you if you're in the United States and whatever time zone you might be in. I'm actually going to be, I wanted to talk a little bit about antibiotic resistance in terms of global governance, and particularly in the context of the United Nations. So to jump right in, as nearly all of you must know, AMR was the topic of a high-level meeting at the United Nations in September 2016. And the high-level meeting essentially indicates that week when the General Assembly is in session, but also a couple of days when global leaders are all there, particularly heads of state, and that's usually what constitutes a high-level meeting. And of course, I didn't know about any of this stuff till AMR was, that we took AMR to that stage. But it was unusual because it was only the 4th time that a health topic had reached that particular forum. The previous occasions had been for HIV/AIDS, for Ebola, and also for non-communicable diseases. And there were lessons to be learned from all of these previous instances when these topics had reached the global level. I think HIV probably the most successful in terms of transforming that momentum into an institutional structure, into funding, and eventually a rolling back of the epidemic, or at least a stopping of the epidemic, for which that UN high-level meeting was very important. I think Ebola was unusual because obviously it's not something that's with us all the time, but it certainly did bring a lot of attention on the potential for diseases, in infectious diseases, in any one place to spread everywhere else. Non-communicable disease was a bit more of a mixed bag, primarily because it encompasses such a wide range of issues, from diabetes to mental health and schizophrenia and to cardiovascular disease, that I'm not quite sure whether that momentum then translated into the kinds of actions that would then result in funding and so forth to be able to address the epidemic. And certainly, non-communicable disease is probably the most important of all of these, if one measures this by burden of disease and economic impact. Now, the story of how this got to the United Nations started much before that. It started with having this issue be taken up at the World Health Assembly, and there being the Global Action Plan that was passed at the World Health Assembly nearly a year and a half before that, and also there was a resolution to then take this to the United Nations. And the reason to take this to the United Nations was at least threefold. One was it was felt that because AMR is unique as a One Health issue, encompassing human, animal, and environmental health, also encompassing many sectors outside of the health sector, that WHO by itself could not do very much about the issue without a broader signaling of its importance and blessing. The second is WHO, as most of you know, is always in need of funding, and and funding restrictions are quite severe. So there was literally no money to be able to do anything on AMR, and it was felt that unless there was kicking up of the agenda to a higher level, that there would not be the attention from either bilateral funders or from multilateral funders or folks like the World Bank to really take this seriously. And of course, the third issue was simply that it was sort of meant to be a moment in time when WHO, I think, in some sense, needed to recapture the centrality of health. The conversations that were going on at the SDGs had sort of slipped away from health a lot more than the Millennium Development Goals. Had been much more focused on health. And there was a need to sort of bring the attention back, and it was important to have this particular issue be discussed at that high-level meeting. So it went to the high-level meeting in September, and apart from the fact that this was the fourth health issue, this was the first One Health topic to make the United Nations at the high-level meeting. And in that sense, it potentially opened the pathway for other sorts of One Health topics to really get there. Now, the document was at the United Nations. The resolution is online. It's available for anyone to read. It's on the UN.org website. But it was a remarkable document. It had tremendous amount of input from countries, delegates who usually would be more comfortable discussing, refugee crises or nuclear disarmament were very quickly got engaged on AMR. They learned the material really quickly. When I say quickly, in about 3 or 4 months, and eventually the document that came out of it was something that anybody who works in the field of AMR should be quite happy with. It did a number of things. It provided a very good description of the problem, the issue that it was global, that actions in any one country would affect all other countries. It highlighted particular issues like access, and the fact that lack of access to antibiotics would cause more harm potentially than resistance, and therefore that itself became a reason to protect antibiotics, because drug resistance is really the biggest threat to access that there is. It provided a link to issues like universal health coverage, which were topics that already had salience at the United Nations, and therefore it made the case that, look, you can't really do UHC if you don't really have effective antibiotics. And it also made the connection more broadly to vaccines, diagnostics, and also much more of a multi-sectoral approach to AMR. And it importantly reaffirmed the Global Action Plan, so it didn't try to push WHO out of the picture. Instead, it tried to build on what WHO had done, and it called upon, in every instance, on actions, which is the last section. It encouraged this tripartite, which had been formed between the World Health Organization, the Food and Agriculture Organization, and OIE, which is the Organization for Animal Health, to work together on stewardship, on surveillance, on innovation, on governance, and so forth. So it was an impressive document. It was unanimously adopted, and it asked for the establishment of an interagency coordination group which would be co-convened by someone at the United Nations and someone at the World Health Organization. It ended up being Amina Mohammed, who is the number 2 at the United Nations, and then Margaret Chan, who is then the Director General of the World Health Organization, to co-convene this IACG, have representation from many countries around the world, and to report back, for the Secretary General to report back in September 2018 on progress. So far, so good. If we're all working on AMR, this is a proud moment that it actually gets the attention that we think it deserves. But did the document actually do all the things that we would want it to do? There are typically 4 things that people who are expert in this stuff talk about, and as sort of the 4 things that the boxes that one should check to make sure that there is actual action when issues get such prominence. The one is, of course, highlighting an attention, which, of course, without a doubt it got. So check the attention box. The second is targets. Anything which has a target on it, whether it's a 1-degree reduction in temperature, if it's climate change, or if it's a particular time for phasing out of chlorofluorocarbons, like for the Montreal Protocol, or if it's if it's something very specific, reduction of infant mortality by 2/3 by a certain date, like the Millennium Development Goals, things where targets get done. And with AMR, there were no targets. The third point was of accountability. So who was actually responsible for action on AMR, and whose job would be on the line if that action did not actually take place? Again, successful arrangements have accountability and governance. And in the case of AMR, there was a lot of pushback to having accountability, and we didn't get accountability. So today, who is responsible or whose job is on the line if the world doesn't do well on AMR? The answer is literally nobody. And that was a lost opportunity, in my opinion. It was felt that, this would not fly, in 2016. But, unfortunately, if we don't push for things to happen, then, the global discussion is happy to settle at a place which is sort of just enough, as opposed to reaching beyond to doing something that really solves the problem. And then the last issues of funding. Successful sort of engagements like this managed to get some kind of money, as was made possible for HIV, for other topics. And in this particular case, there was no money that was allocated. So today, global antibiotic resistance is funded because of the generosity of a few governments like the United Kingdom, and the United States obviously funds stuff within the US, but by and large, there is nothing like a global fund. There's far more money for HIV, TB, malaria, and so forth than there is for AMR. Well, I'm not saying that it needs the same level of funding, but there is no funding whatsoever, which is truly global. And the WHO office that deals with AMR is also seriously underfunded and is not able to undertake very simple things that they really should be able to do. Now, there was also a sort of an idea that tying this to the Sustainable Development Goals, there are 17 Sustainable Development Goals, and it's an interesting list. It covers everything from number 1 is no poverty, number 2 is zero hunger, number 3 is good health and well-being, 4th is quality education, etc., etc. And colleagues working in this field have tried to sort of tie everything to the SDGs because there is buy-in in the SDGs. I happen to think that the link to most of the SDGs is a bit tenuous. I mean, we can wishfully tie anything to anything, but I don't see how we can really tie AMR to life below water or necessarily to peace and justice and strong institutions. I think it's a very strong tie to certainly to livelihoods because of agriculture and agricultural use of antibiotics. There is certainly a tie to good health and well-being where it's absolutely most direct. But there's still a move to try to connect it more broadly to the broader SDGs, which in a sense, at least it's my opinion, that's a bit of a waste of effort because there's a very clear case to be made for AMR. This is a global crisis as it's happening. We don't have to claim that AMR is important for sustainable cities to do something about it. I think it's important to do something about AMR because nearly 1 million people die because of it every year, and that number is only going to go up, and that's the reason to do it. But that's just my personal opinion, and I'm just pragmatic about seeing what will get us furthest in the shortest amount of time, and that's sort of just my thought process about this. Now, the IACG itself was constituted. It's an excellent group, but many members of the IACG have expressed privately frustration with the fact that it got started very late. It doesn't have any funding whatsoever. And, beyond just being another committee, and we've had lots of committees on AMR going back to the SWAN report, the OTA report, what exactly is the IACG going to be able to do that brings us those issues of targets, accountability, and funding? And the answer is hard to tell. So are we better off with an IACG, the Interagency Coordination Group, than without? Undoubtedly so. But should we have aimed for something beyond that, potentially a United Nations AMR, UN AMR, along the lines of UNAIDS? I think that's what we really need. We need, I know the word bureaucracy is sort of a bit of a dirty word, but what a bureaucracy means is that someone's got the budget, the mandate, and also the responsibility to do something. And if they don't carry out that responsibility, then their job is on the line. And again, to come back to that, we don't have an agency whose job is on the line if they don't deliver. And unless we have that entity, we're not going to really make progress. And this could stall very easily. And then there's a danger to have taken it to the United Nations, because then the world says, well, this is an important problem. You had your chance and you took it to the UN, but then what really happened after that? And lastly, let me be clear that because of the nature of AMR, it is not something like, say, for instance, the Montreal Protocol, which can be solved entirely, with the ozone hole, which can be solved entirely by regulation by governments. This is a topic which is going to require broad collaboration across society. It's going to require the pediatricians, the nurses, the pharmacists. It's going to require the hospital associations. It's going to require consumers. It's going to require certainly governments. But this is not a topic that can be solved entirely just by governments, either through spending or by regulation, and is therefore unusual in that sense. Comes closest to climate change in that respect. And so we really need to not imagine that the United Nations alone can solve this problem or even begin to solve this problem unless we are broadly engaged in it ourselves. To this end, we had formed a coalition called the Conscience of Antibiotic Resistance Accountability. And this is basically about 80 organizations around the world that we're going to try to hold the United Nations accountable for actions, and also to make sure that progress did not stall, and that promises that have been made would be kept, and to help make that progress. And we've been waiting and watching, and we're just not seeing much by way of progress. Globally, there are country-level examples of progress, to be sure. I think the progress on national action plans has been amazing. There are many things that are going on, in various countries, which offer hope. But we recently published, CIDRAP recently published just earlier this week, a paper in the Proceedings of the National Academy of Science showing that the increase in antibiotic consumption around the world continues unabated. Now, this is over a period from 2000 to 2015, so it certainly doesn't cover the period after 2016. But I am willing to bet that that trend has not changed since 2016, either in developing or in developed countries. And unless we actually have data, draw baselines, set targets, and measure progress, we won't even know if all of this action at the United Nations has made any difference at all. So it just comes back to measurement and data, and of course to get people to pay attention to progress on the basis of such measures. To this end, we have a second edition of the State of the World's Antibiotics Report that will be released in a couple of months. And we're basically setting out baseline dashboards for countries to then be able to measure that progress on antibiotic resistance. So I didn't want to speak for the hour or anything. I just wanted to, just give you guys a sense of what I thought had happened in the United Nations and what we can expect from that process. But I look forward to questions and to discussing this with all of you. Thank you very much for listening.
Thank you, Ramanan, very much for the overview and some of the progress or frustrations that may have occurred over the last 18 months since the United Nations Special Assembly that occurred on the topic in the fall of 2016. I'll start off with a few questions that came to mind as you were speaking. And our participants also can see that we've got, as well as we had highlighted there, Ramanan's group's website prior. I sent it out to our participants as well in the chat box, but also our Antimicrobial Stewardship Project. So what came to mind is that the interagency coordinated group was formed between the UN and the WHO, and you highlighted basically 4 things that are important. One of them being creating awareness, creating those targets, accountability, and funding. It seems to me that really where it got stalled was, or has been stalled, is first with the accountability. I would assume once there are particular groups that are held accountable, that then you'll be able to set targets with stakeholders and then start to proceed and get the funding you need. And I don't know if you agree with that or not, but I'm just wondering what do you think is some of the problems related to the accountability?
So thanks, Marnie. I think fundamentally we don't have an accountability structure. So an accountability structure in the case, again, to go back to the Montreal Protocol for reducing chlorofluorocarbons and to prevent the ozone, to protect the ozone layer, countries had to sort of commit to removing the CFCs in refrigerants by a certain date, and they had promised to do so by a certain date, and then there was a follow-up to make sure that that actually happened. Similarly, if you look at the Paris Agreement for climate change, there are commitments to reducing, carbon emissions. Now, in the case of antibiotics, it's not straightforward. We don't necessarily want people to just across the board saying, I'll reduce antibiotic consumption, when many of the people don't really have antibiotics in the first place. But what we're seeing is a wholesale move away from first-line antibiotics towards far more, what we would consider unnecessary, because, in the the WHO list has this aware list, right? So the ones that are absolutely needed, the watch list, and then the reserve list. We're seeing a lot of drugs on the watch and reserve list being used as opposed to ones that should be used because they still work. And that constitutes accountability. It constitutes accountability when someone is able to measure it, and then countries are sort of, at least highlighted for not making that progress. that part we're missing, and pretty much anything else, even for protection of fisheries, for instance, accountability mechanisms do exist. They might involve self-reporting, but at least there's some self-reporting. We don't have that right now, and the only thing that sort of comes anywhere close to that is sort of the idea of GLASS, which is just a global surveillance system. And the global surveillance system is just to provide data back to the center. It's not necessarily to ask countries to do more and to then say, well, why are you not doing more? Unfortunately, we need that. That's the only way in which progress happens.
You mentioned, and I want to talk a little bit about access to the antibiotics, because that is something you've mentioned at the beginning of your conversation, and also again, for those people that are not aware of the problem with access in some countries. If you just talk a little bit about your work in that area.
Sure. So we highlighted this in a paper in the Lancet series that came out in 2015 on access to affordable antibiotics. And I think that drug resistance is a huge threat to access. As it is, there are millions of people who die because of lack of access to antibiotics. Anyone with dying of pneumococcal pneumonia in India, that's lack of access, because penicillin works to treat pneumococcal pneumonia. And why do these people die anyway? That's simply a lack of access. Various reasons. I mean, maybe they didn't know they needed to get an antibiotic. Maybe they didn't have the money to pay for the antibiotic. Maybe the penicillin was not available in those places. So there's a lot which deters access, and we're still trying to learn about these. And so in the face of that, we don't necessarily want to say, well, everyone should be using less antibiotics. I think what we want to say is that everyone who's overusing antibiotics should be using less antibiotics. But there are certainly many people around the world who should be using more antibiotics, and appropriately so. That's why this makes it a more complicated issue than dealing with, say, with tobacco. I mean, no one is dying because of lack of access to tobacco, as far as I know. But I think people are dying because of lack of access to antibiotics.
So Raman, we did have a question come through the chat box, and people are wondering, or participants wondering about, how do you engage with, middle to lower income countries that have so many other pressing issues to deal with? How do you engage with them to try to make these commitments to the issue related to antimicrobial resistance? What's their perspective?
I think low and middle income countries probably suffer more from drug resistance than even the high income countries, because the lack of access to antibiotics is only going to be exacerbated as the first line drugs stop working and as they continually stop working. So certainly they have other pressing issues, but if you think of providing health as being a central concern of these countries, then AMR rises quite high to the top. And also it's important to remember that many actions that we have to take to solve the problem of antimicrobial resistance will have knock-on benefits for the health system. For instance, improving drug quality and regulation of drug quality. You can do that for AMR, but it has benefits across for all drugs. Improving, utilization of drugs to make sure that appropriate drugs are sold over the counter, and drugs which shouldn't be sold over the counter are not sold over the counter. That has benefits for antibiotics, but it has benefits probably for other classes of drugs where people are unnecessarily harmed because of drugs that they got from a pharmacy when they shouldn't have really got that drug. Third, if we really emphasize infection control in hospitals with a view of reducing the use of antibiotics, that has benefits which are unrelated to AMR. That's just directly reducing infections. Similarly, vaccination programs. Countries should definitely do vaccination programs, and having this benefit of reducing use of antibiotics is an important additional benefit of the vaccination program. So I don't think thinking of AMR as a standalone issue helps. I think recognizing its connectedness broadly to the health system is important, but solving AMR will have benefits for the health system, and therefore it is urgent that they take this on.
And that actually makes a lot of sense. It's almost like remessaging and recreating the approach to the problem and how it's integrated into across all the different aspects of health. So I wanted to also ask, again, back to these 4 things that are critical to this being successful is the funding aspect. And you mentioned a couple times that there's basically no funding or very little funding related specifically to antimicrobial stewardship. Some funding that has been available related to antimicrobial resistance has been targeted, from my perspective, and looking at this, is more targeted towards the development of new antimicrobials to treat now these multiply drug-resistant organisms that are a problem. But it seems as if the funding has not been available to maintain, through stewardship practices or surveillance practices, antimicrobial stewardship issues. So is that something that you feel is you've noticed, and what are we going to do about this? How are we going to get funding for this?
Well, it's not an either or, but it's certainly a concern that much of the funding for AMR has gone to new drug development, which I think is probably not the appropriate balance of spending. We should be spending more on stewardship than we do on drug development per se, because if we can conserve the antibiotics that we have, that reduces the need for new drugs. And on the flip side, just developing a new antibiotic without changing our incentive for conservation basically means that that new drug is going to be useless just a few years after it's introduced. So we've spent, billions of dollars on something that's not quite dead on arrival, but it's dead soon after arrival. Now, unfortunately, the pharmaceutical companies have been quick to seize the initiative to use AMR as a recruitment of funding vehicle, saying, well, they really need this to develop new antibiotics, and it's been easier for the politicians to spend the money on that. As a community that's interested broadly in AMR, both on new drugs as well as on stewardship, we have not communicated adequately that this is probably a flawed approach and that we really need far more money in stewardship. So, again, at the end of the day, who's accountable for it, and in a sense that who's stepping up for this? It's really all of us who work on this. And if we haven't made that case well enough, then we've just not done our jobs.
Do you feel that there almost an approach could be that it needs to come almost a grassroots effort where the clinicians, the researchers in the field globally come together, and I'm aware that that's basically what you're trying to do in bringing together Cara and your partners to try to bring this grassroots effort together, which then influences the UN or WHO global policymakers and partners to then take this on as a much more serious problem with appropriate funding, with appropriate targets. Is that almost, we have to turn it around instead of thinking we can get the UN interested and then it comes down with accountability and facilitates at the grassroots level, that it almost has to be from the bottom up?
Absolutely. This is not a problem that's going to be solved by the UN. I hope I got that point across clearly. If we think that, yes, we've lifted this all the way to the UN and now they'll take care of it, it's not going to happen that way. I think we need to constantly hold them accountable, and we have to make sure that we're making sure that the funding becomes available, that there's constant sort of questioning of what's going on. Think of the HIV epidemic. It was stopped not just by UN actions. It was stopped by people, patient advocates, physicians working on this, everyone involved in it, really, and obviously, celebrities and so forth. Everyone really, shouting from the rooftops about how important it was. If it had been up to just the United Nations, we probably wouldn't have had that action on HIV. So I think it's absolutely critical that communities like Tara and others really take this forward in a way that that complements the UN. The UN can also do stuff, but we have to make sure that they're doing it.
How are there ways that people are listening now that are clinicians or they are researchers working in the area? Are there ways that individuals can engage to try to help promote the mission and bring awareness of AMR? Are there organizations that they can be a part of, or
I'm guessing you're looking at two folks out there, right?
Yeah, how does an individual become a part of this? Obviously, they can follow it and read and become educated in the area, and they're acting locally, but they're trying to have this impact in a more global aspect. That's what I was addressing. And I think, Ramanan, you're on mute right now.
Yes, I was just waiting to see if anyone, addressed the question.
Yeah. The other question that came in from one of our listeners is, how can we get the concerned communities, so researchers, clinicians in the area, get philanthropic organizations to consider AMR as a funding need? This is a good question, because for those of us that work in the area, including our antimicrobial stewardship projects, a lot of the philanthropic funding missions or they'll fund specific areas, but antimicrobial resistance is really not on their radar at the moment. It's not listed as something that you can engage with them on. Yeah, I think this is a very good question, is how to get the philanthropic organizations up to speed on this as a problem that they would want to fund it.
That's a very good question. I don't know if it's the same hook for all philanthropic organizations, because they all have different foci. Like, for instance, some organizations might be interested in the research angle of this. Some might be interested in patient needs. Some might be interested in a link to child survival. Some might be linked to helping make sure that the food supply is organic or free of antibiotics. So I don't think there's one answer here, but I think the beauty of AMR, if there is one, is that it lends itself to many different needs, perspectives, and interpretations, and therefore could attract very different kinds of groups to come in. Nobody's going to own, you can't go out there and just say, well, can I fund the entire thing just from you? It's just a question of what intersects with that piece. Take the Gates Foundation, they're interested in child survival, so we see if that, the parts that link to child survival and vaccines might be linked there. Similarly, if you think of foundations that are interested potentially in funding behavioral research, there's a lot of behavioral questions that relate to AMR. Why do physicians so easily write antibiotic prescriptions? Why do patients, feel like they have to get an antibiotic every single time? So I think there's a richer answer that than I can actually provide in a short time. Yeah. It's not easy.
No, I think that's a really good point, though. How AMR intersects with a lot of different concerns, and so that just highlighting how it intersects and is connected would be a value, and we need to think a little bit more creatively. So another question that came in, Ramanan, is wanting to know your thoughts of the recently published WHO Global Antibiotic Resistance Surveillance System, the GLASS report, if you're aware of that, and if you had any surprises with that report or any issues that you wanted to highlight.
The main issue with GLASS is that it's not, because it's data that's provided by governments, and because governments don't really have surveillance systems, it has huge gaps for that reason. WHO is fully aware of this, but because of WHO being a membership organization, you and I cannot feed data into GLASS. It has to come through the national government. And so countries which have made the investments and which are willing to report the data, you get good data, but it's highly, highly variable. And it goes back to a point I made earlier, which is in the absence of global public funding for AMR, there is simply not the money to sustain the expansion of something on the ground that is needed to support GLASS. And the Fleming Fund is trying to do that. But the Fleming Fund will take at least 4 to 5 years before it makes a difference on the ground. So this is really a problem.
And you mentioned that the World Antibiotic resistance report will be available in a couple weeks?
No, a couple of months.
Oh, a couple of months. Okay. And that will be made available through your website?
We'll do a full launch of it, just like, we do for all the papers. And we did for the State of the World's Antibiotics report the first time around. That's
excellent. So we'll be able to have access to that as well. Mm-hmm. So circling back to the title, what can the United Nations do about AMR? You mentioned that there's a report that's due back to the United Nations in September 2018.
Uh-huh.
And so, and I suppose a lot's going to depend upon that report. Like you said, will it have failed? What are the next steps? What can we do to continue to move this through as an issue within the United Nations? So do you have concerns with that report in September 2018? It sounds like you do, that perhaps not enough was done. And are you worried that this may be a failed issue that we can't take forward?
2 years is a very short time in the way the world operates. So it may not show a lot of progress, but I'm sure the UN will come up with something which says, yes, all this is underway and so forth, and enough to sort of get by. But it's just knowing what's going on, I don't think we're making the progress at the speed that we need to deal with this. Resistance is definitely going up much faster than the action to counter resistance is. So I'm not concerned about necessarily the report, because it's really going to be, when that report comes out, the media and everyone else is going to turn back to folks like who are on this call and say, what do you think? Do you think that the progress has actually been made? And is what countries, what countries are reporting, is this consistent with what you see in the real world? And that will be the interpretation of that report and the perspective on it. It's not going to just be, what a particular agency or the UN system actually says happened.
Well, Ramanan, I thank you very much for your time, and thank you to our participants. We don't have any more questions coming in at the moment. I don't know if you have any closing comments for us. This is, just remind you and our participants, this is a recorded webinar that we'll have available on our website next week. And so if anyone was not able to attend, they'll be able to listen to this very important webinar. I don't know if you have any closing comments.
Nothing, just to say that, this is obviously a conversation to be continued, and, everyone is on the call, certainly I'm sure is already engaged and, on the topic, and we need to bring a broader community of people, to engage on this. HIV had, tens of thousands of people who were engaged. I think AMR maybe has a few hundred. We need to change that.
I think that's a great way to end the webinar. It's about engagement. So thank you very much, Dr. Laxminarayan, and good luck with your future reports. And we appreciate all your efforts and your work, and appreciate your partnership in creating this engagement and awareness around AMR. And thank you to our participants for joining us today.
Thanks for having me.
Everyone have a good weekend.